Good evening, friends. On behalf of Team MAHAIP, I welcome President Dr. Upendra Kinjodekar, sir, MMC Observer Dr. Vaibhav Pustake, sir, all dignitaries, both the experts, presenters, team participants from both the teams, then IIP members and PG students as well. Today, MAHAIP is starting its first episode of MAHAIP Case Challenge of this year. Last year, Dr. Mahesh Moite, sir, has taken initiative to start this interesting case challenge activity. Now, this year, Dr. Pramod Kulkarni, sir, has taken the lead to continue this activity with the help of President Dr. R.D. sir and zonal coordinators, namely Dr. Rajendra Khadke, sir, from Chhatrapati Sambhajinagar, then Dr. Anjali Gokan from Virar IIT, Dr. Deepa Firke ma'am, who is Professor of Pediatrics in GMC Miraj, Dr. Ravindra from Nashik, Dr. Ramesh Saide from Amravati. We have planned to conduct 2 episodes in each month with a gap of 2 weeks. In each episode, there will be 2 presenters from different IP branches. They will be presenting their interesting cases to 2 teams, and that team of 3 participants have to crack that case in front of experts, PG teachers, who will be asking questions in between to above all members. So they all will take us in our PG days, that is case presentation and Viva. Now, today we have 2 experts. First, Dr. Bhavna Laskar, she is a PG teacher from Nagpur, and Dr. Mahesh Kore, who is a senior pediatrician and clinician from Nipani, Belgavi. There are 2 presenters. First is Dr. S.N. Shankar Gowda, who is in Miraj, and Dr. Pawan Devre from Nashik. There are 2 teams. First team is from Hingoli IIT, Dr. Nitesh Chaudhary, Swapnil Giri, and Dr. Amol Deshmukh. And second team is from Mumbai IIT, include Dr. Rajesh Kasla, sir, Dr. Ripa Agarwal, Dr. Sikha Agarwal. This session will be moderated by Dr. Deepa Firke ma'am and Dr. Tripti Mahatme, who is editor in MAHAIP team. I request all the office bearers of MAHAIP branches to send the team of 3 to 4 participants from your branch who should be IIP members first, and please send this team as early as possible. These teams will be taken in successive sessions. Now I hand over to Dr. Tripti to take you in to take you all further in. Over to you, Tripti.
Thank you, sir. Thank you so much. So, respected seniors and dear colleagues, it's our immense pleasure to bring you back to the second series of brainstorming session of MAHACASE Challenge. On behalf of MAHAIP, I once again welcome all the respected experts, presenters, and members of both the team from Hingoli and Mumbai. As sir has already told you, this will be a series with 2 new experts, 2 new presenters, 2 new teams, and 2 new interesting case challenges. I would like to inform you that 1 MMC credit point has been sanctioned, and I request everyone to please post your names, MMC registration numbers, and IIP numbers to avail this benefit of credit point. I also request you to please post your queries in the chat box, which will be taken in the end of the session. And during the session, please keep yourself muted. Now, I request respected President MAHAIP, Dr. Ramakant Patil, sir, to address the participants and the delegates. Over to you, sir.
Thank you, Trupti. Good evening, Honorable President, Dr. Upendra Kinjodekar, sir. All my colleagues and this case challenge team. Particularly, I am very thankful to Dr. Pramod Kulkarni, sir, who is my EB colleague, for accepting this Herculean task and putting this MAHACASE challenge again back on the tracks. Friends, we are all clinicians, and what is most important is that most of the time we are clinically alive, but academically we are many times are pulseless. So to revive both the things, clinical and academics, so I think this combination will be best done by these case challenges. Otherwise, it is a many times one way traffic. And to avoid this one-way traffic, this MAHAKESH challenge series 2 or this thing is being brought on track by efforts of Dr. Pramod Kulkarni, Dr. Anjali Gokarna, Dr. Neha, and Dr. Trupti. And we have got, as Amol has said, that we have got regional coordinators for this. But most important, those who are attending this, I request them to bring all the good cases from presenters, and those who will be bringing the cases, he will be the presenter for the sessions. And person from which district is bringing the case, the team will be some other district. And here what we want, a clinical approach. The approach is most important rather than what is the diagnosis. And we have got very eminent experts today. Our friend and a very academically and clinically sound person, Dr. Mahesh Kore, who is following the footprints of Honorable respected Amdekar sir. And also we have got Bhavna Lakkar madam. And we have got a presence of our senior member, Dr. Alok Gupta sir. My friend from as a MMC observer, Dr. Vaibhav Pustake is there. And I welcome the two teams for volunteering to crack this case, and two presenters, Dr. Shankar Gowda, Shreyansh Shankar Gowda, and Dr. Pawan Devre. And probably this will be the most enchanting and gratifying session. And I will not take much time, as we should be doing without much ado. We will move forward, and I'll hand it over back to Trupti for further proceedings. Thank you, Trupti.
Thank you so much, sir. Now I request to share his thoughts and words of wisdom. Over to you, Kinjavadekar sir.
Yeah, good evening, Dr. Tripti, the respected MAHAIP President, Dr. Ramakant Patil, Secretary, Dr. Amol Pawar, Senior IIP member, Dr. Alok Gupta, and my dear friends and colleagues, Dr. Vaibhav Pustake, Dr. Mahesh Kure, respected Dr. Bhavna Lakkar, Madam, and the two presenters, Dr. Pawan Devre, Dr. Shankar Gowda, the teams of Hingoli and Mumbai. I think, and along with Tripti and Dr. Deepa Firke is also the co-host for the program. And of course, Pramod Kulkarni, the EB colleague, as Ramakant was introducing him, Ramakant is also equally good at all these academic events. I'm very happy that such two giants are there, part of this EB team also. And more importantly, I'm happy to say that the good work. You know, sometimes, many a times, the president tenure finishes and the program gets over. Program which was started when Dr. Hemant Gangulia was the president, and it was immensely popular MAHAIP Case Challenge series. And when was conducting it, and then of course Pramod is continuing that part, and I'm extremely happy and proud of Ramakant and team of MAHAIP that they're continuing the good work. This is what the message should go, that irrespective of the person in chair or not, good program should always continue in IP, and you're doing a great job. I'm very happy for that. So I've been bringing greetings from Rajkot. So yesterday and day before yesterday, we had our SSS program orientation, and I'm happy to say that Rajkot IIP is having their first annual conference on Sunday, and on the pre-conference workshop kind of thing, they're doing the SSS program tomorrow in two schools, in the morning one session and afternoon second session. So I've come for that program over here, and there are about 30-40 pediatricians who have already registered for that. So just wanted to give an update since it was a fresh event yesterday. So my greetings and then best wishes for this MAHAIP Case Challenge. And I'm sure, as Ramakant said, it's not the final diagnosis that matters. Of course, ultimately it matters, but the methodology and approach to the case, that is actually what is important, and that it should be learned with the help of these experts. So my best wishes to all the future episodes of MAHAIP Case Challenge. And I'm sure, like last year, this is also going to be extremely popular, and people are going to look forward for very fascinating episodes of this MAHAIP Case Challenge. Thank you so much for your kind invitation, and best wishes again. Thank you.
Thank you. Thank you so much, sir, for your blessings. Now I request Dr. Vaibhav Pustake, sir, to say a few words. Sir is an MMC observer for today's session. He is a senior pediatrician from Pimpergaon district, Nasik. Over to you, Vaibhav Pustake, sir. Sir is there?
Yes, ma'am. Sir is there.
Dr. Pustake, sir? Okay, I think we'll listen from him later on. Now, I request Dr. Pramod Kulkarni, sir, who is the Chief Coordinator for MAHACASE Challenge, to brief everyone in short regarding the program.
शुभ संध्या सर्व
Kulkarni
श्रेष्ठ.
sir, you should not be in short. You take your own time. This is the first episode. Please give us further guidelines also. So
ऐकू येते रमाकांत?
yes, you need not be in short. You may be
Okay,
elaborate.
okay. नाही, सर्व श्रेष्ठ ज्येष्ठ सहकारी आणि मित्र आणि सहभागी प्रेक्षक बालरोग तज्ञ सगळ्यांचं मनपूर्वक स्वागत. इवलेसे रोप लाविले दवारी तयाचा वेलू गेला गगनावरी. डॉक्टर आंबेडकर सारख्या आपल्या अतिशय सन्माननीय आणि पूज्य शिक्षकांनी लावलेलं हे क्लिनिकल पिडियाट्रिक्सचं जे रोपटं आहे, गेले 3 पिढ्या आपण याचे अतिशय भाग्यवंत असे हे आहोत, श्रोते आहोत आणि शिष्य आहोत. आता हे एवढं पुढे गेलेलं आहे, याचं महाकेश चॅलेंजच्या रूपाने डॉक्टर महेश मोहितेंनी मागच्या वर्षी हा अतिशय उत्कृष्ट असा कार्यक्रम चालू केला. त्याला अतिशय उत्कृष्ट प्रतिसादही मिळाला सर्वांकडून. यावर्षी आम्हाला खूप आनंद होतोय आणि मी फक्त इथे आहे आणि हा कार्यक्रम चालू आहे तो सेंट्रल IAP, MAHAIAP आणि आमचा चमू हे सगळे बघणारे आहेत, म्हणून हा कार्यक्रम एवढा छान सुरू होतोय आणि छान सुरू होणार आहे. मी एक त्यातलं निमित्त मात्र आहे. तर आता या कार्यक्रमाविषयी आता थोडे दिवसाचा गॅप पडलेला आहे, तर पुन्हा एकदा तुम्हाला सांगायचं म्हणजे क्लिनिकल स्किल्स येणं, प्रत्यक्ष वापरणं आणि केस चॅलेंजच्या रूपामध्ये एका क्विजच्या रूपामध्ये फेस करणं, ह्याच्यामध्ये प्रचंड फरक आहे. त्याला प्रेझेन्स ऑफ माइंड लागतो, क्लिनिकल बेसिक अॅक्युमेन लागतो, वेळेमध्ये त्याचं कन्व्हर्शन लागतं आणि एकत्रित चमूचं तिन्ही टीमच्या मेंबरचं कोऑर्डिनेशन लागतं. तर आज आपण अतिशय भाग्यवंत आहोत. पहिल्या 2 आपले संघ आहेत, हिंगोली संघ आणि मुंबई संघ. त्याच्यानंतर सादरकर्ते आपले 2 अतिशय छान क्लिनिशियन्स आहेत, त्यांच्या अतिशय छान केसेस आहेत. आणि आपले तज्ज्ञ आज असलेले डॉक्टर महेश कोरे आणि लाकर मॅडम, अतिशय सुंदर चमू आहे. सगळं काही जमून आलेलं आहे आणि आता आपण याच्यामध्ये सहभागी होऊयात, एन्जॉय करूयात ही आजचे केस प्रेझेंटेशन. फक्त तुम्हाला एकच विनंती आहे, कोणत्याही प्रकारे याच्यामध्ये टिप्स देणे, क्लूज देणे किंवा तुमची उत्तरं सांगणे एवढं कृपया करू नका. ही जी मंडळी आहेत इथं, ही दिग्गज मंडळी आहेत, त्यांना कुठल्याही मदतीची गरज नाही. कानाकोपऱ्यात महाराष्ट्राच्या राहणारी आणि टॉपमोस्ट मेट्रोमध्ये राहणारी, जरी तांत्रिक प्रगती सगळी आणि तंत्रज्ञान प्रगती असली तरी क्लिनिकल स्किल्स इथं टेस्टला आहेत आणि ते त्यातले अतिशय माहिर आहेत, रेकमेंडेशन मिळून आलेले या टीम्स आहेत. तर माझी तुम्हाला विनंती राहील, याच्यामध्ये सहभागी व्हा आणि तुमचे इनपुट्स तुमच्या पाशी ठेवा आणि ऍट द एंड ऑफ सेशन आपण याविषयी निश्चित चर्चा करू. सर्वांना मनापासून शुभेच्छा आणि पुन्हा एकदा आभार आणि आपण पुढे जाऊयात या कार्यक्रमाकडे. आभारी आहे.
धन्यवाद सर, अतिशय सुंदररित्या विषयाची मांडणी केल्याबद्दल. नाउ आय हँड ओव्हर टू डॉक्टर दीपा फिरके मॅडम फॉर फर्दर प्रोसिडिंग्स. ओव्हर टू यू मॅम.
Okay, thank you, Trupti. So yes, with the wishes of our President, Dr. Kinjavdekar sir, R.D. Patil sir, and of course the brainchild MAHAIAP case challenge, the brainchild of Mahesh Mohite sir, we are quite excited to restart this session, and we are honored to have with us 2 experts, and I'm honored to introduce these experts. The first expert is Dr. Mahesh Kore, who is an eminent pediatrician from Nippani. As R.D. sir has already said, he is following the footsteps of Dr. Ambedkar sir, and we call him the Sherlock Holmes because of his ability to crack cases through small clues. So yes, we are hoping to see his the case cracking and his expert comments on this session now today. Welcome, sir. We have the second expert, who is Dr. Bhavna Lakkar. She has a huge teaching experience of 36 years. She's a PG guide and a PhD guide too, and on nearly around 100 publications on her name. Welcome, ma'am, and we are also eager to hear your expert comments for this session. So the first presenter for this session is Dr. Shreyansh Shankar Gowda. He's an eminent pediatrician from Meerut with a experience of around 25 years, and his interest is in intensive care and cardiology. So welcome, Dr. Shankar Gowda. And of course, our challenge takers today is the enthusiastic Hingoli team. And it's Dr. Nilesh Chowdhury, Dr. Swapnil Giri, and Dr. Amol Deshmukh from the Hingoli team. So few instructions before we start. The time allotted for the case is just 45 minutes, which also includes the expert comments. So we need to be in time. A request to the experts, you can intervene in between if you feel that the case is going out of the track, and your expert comments are definitely welcome. All the participants are requested to keep their videos on. And for the viewers, you can write for the MMC credit point, you can write your name, your place, and your IP number and MMC number in the chat box. So yes, I request now Dr. Shankar Gowda sir to present his case. Over to you.
Thank you, ma'am. Thank you. Thank you, moderator and the dignitaries. I'll just start the case. Hope I'm audible.
Yes, you are audible and your screen is visible.
Yeah, thank you. Yeah. This was a 3-month-old girl child.
Your slides are not been seen.
The slides
Are not seen, sir.
okay.
The screen is seen, but
Yeah,
your
yeah.
presentation.
I'll just see what. Is it seen now?
No, sir.
No. Oh.
Dr. Shankar Gowda, you
Yes, sir.
minimize this, open it properly in your screen and then do share screen.
Minimize the. Okay.
Exit from. You stop sharing the screen, open it properly on your
Okay, sir.
desktop and then share again.
Okay, sir.
Thank you for adding me.
पल्लवी मॅडम तोपर्यंत युट्यूबला मेसेज आपल्या वेटिंग रूमला मेसेज टाका ना. Those who are not able to join because of
Sir, टाकते मी टाकते
हाँ,
सर constantly टाकते sir.
They can
Is it
join
seen now,
through
sir?
YouTube. Yeah.
The screen, is it seen now?
Sir, screen is
Slides?
visible, but open your slides, sir.
Slides have opened, madam, but I don't.
No, minimize this screen. Minimize this screen of your folder, MAHAIP folder. Make it minimize.
Okay.
Because we can see your folder screen, sir, not the presentation.
I don't know why it is not being.
Just stop sharing.
Yeah.
Open your presentation first, not the folder,
Okay, madam.
and then again share, sir.
Yeah.
Yeah. Thank you, sir.
Yeah. Is it?
Yes, sir.
Yes. Make it full
visible.
screen.
Yes, sir.
Yeah. This was a 3-month-old girl child who was
You can
rushed.
make it full screen.
Slideshow.
Slideshow view.
Yeah.
Sir, beside
Top.
animation, slideshow button is there. On the top, home
Yes.
insert.
Yes.
Yeah.
Near
Yeah.
that. Near
Yeah,
that.
beside that, sir, slideshow. Click
On
on
right
the
side.
slideshow.
Yeah.
Yes. Yes.
Yes, sir. Yes, sir. And
From
from
beginning.
beginning. From
Thank-
beginning.
Thank you.
Yes,
Yeah.
sir.
This
Thank you.
is a 3-month-old girl child who was rushed because she was throwing fits continuously.
and apparently all right a week ago she was rushed in because she had episodes of fits since last 1 week, and before around 2 years before the child was brought to our setup, the child's fits had increased. At presentation, the child had high grade fever. Next.
Sir, Nitesh and his team is logged off.
Don't know what is happening. Draw text mouse. Yeah. Yeah.
Hello,
Yes, sir. This is the child.
Dr. Neha.
At presentation, this was the video.
Yes, Amol sir.
Is the video visible?
Yes, yes, yes.
The teams, please, is the video visible?
Yes, sir.
video is
Visible. Please go ahead.
Yeah. So this was the child at presentation. As we see, child's breathing was well and the circulation was normal with spontaneous eye opening. The tone and movement as we see in the video was normal. The child was irritable, was not feeding well, and had high grade fever. So the sugar, the glucometer reading was 94 milligrams per deciliter. And the sodium at presentation, the bedside report was 135 of sodium with potassium of 2.9. And ABG, as we see, the pH of 7.59 with PCO2 of 24.8. And the CSF was done before the child was referred to us. The CSF was normal with normal cells, proteins, and sugar. At presentations, we gave a sodium valproate loading, antipyretic, piperacillin, tozevectam, and azithromycin was started. The CBC report with hemoglobin of 8.3 and total count of 15,200. And as we see, the neutrophils were 30% and lymphocytes of 60%, with monocytes of 8%. And the platelet count here is normal, 3,89,000. We obtained after, since the sugar was normal, the child was converging, a 3-month-old child. The ionic calcium was reported to be normal, 1.04. Is the report seen? Are you able to see the report?
Yes.
Yes.
Yeah, and the serum magnesium report was 1.42, which the normal reported value was 1.5. So there was slight reduced magnesium for which the child received magnesium. Now, this was the presentation after almost 24 hours. The fits, the child had 1 or 2 episodes of fits, and the child was having spontaneous eye opening in between. Are we able to see the video?
Yes.
Yeah. As we see the child's, there was paucity of movements on the right side. I'll play the video again. There was paucity of movements on the right side. The left side tone was normal, but the right side there was reduced tone and reduced movements. The child continued to have high grade fever. With that presentation with a paucity of movements on the right side, we thought of doing an imaging.
Doctor,
Yeah.
you can ask the participants like in case they want to analyze the case.
Yeah. So at this moment, the MRI was done. And do the participants need any more information until then? At this moment?
Shankar Gowda, you can ask on clinical history, what are your thoughts? And then we can proceed with the investigation.
Yeah, this is the clinical history. As we, I will just summarize. It was a 3-month-old child, was having repeated, was apparently all right a week ago and has started throwing fits. And last day, the child's fever had increased and there was repeated episodes of fits, for which the sugar was done. Ionic calcium was normal, sodium was normal, potassium was 2.9, ionic calcium of 1.01, and serum magnesium was borderline reduced, just 0.1. Intramuscular dose of magnesium was given. The child had 2 or 3 episodes of fits that day, but that day evening there were reduced movements on the right side. and the episode
Can I
of
interrupt? Can I interrupt once? Miss, whether team wants to ask any other
yes,
important finding.
yes.
The
The
team,
teams, please.
whether they want to ask any important question.
Teams, please.
Team Hingoli. Team Hingoli. Dr. Nilesh Chowdhury.
Before we go to the findings and this
Yes.
clinical examination, whether we thought
Anyone from
will
team
give
Hingoli?
importance to the. If
Please
nobody wants
check whether Dr. Nitesh Chaudhary, Dr. Swapnil and Dr. Amol is there or not, or whether they have been logged out.
Sir,
I
they
will
have been logged out. They are listening on YouTube, and we are trying to join them again. We can proceed.
Okay, madam. So with that episode,
No. We don't have
I
to
think-
proceed. We
No,
have
I
to,
Because they need
whoso has taken a challenge, please
Yes.
let him have free access to the
Yes.
questions and other things.
yes,
Otherwise, it won't become an interactive session.
yes, yes.
Pallavi ma'am, please bring these three people, Nitesh Chaudhary, Swapnil
Yes, sir.
Giri,
Sir,
and
we are
Amol.
trying. We are trying, sir.
Yes, please.
But I want one more answer, like one more clinical finding.
Yes,
which
madam.
is very important at this point.
Yes, ma'am.
What about the fontanelle?
The fontanelle was, there was no bogginess. The fontanelle was, it did not suggest a raised ICP.
It was not bulging.
Yeah.
And it
And the
was not
CS,
bulging.
yeah. Yes, madam. And the CSF was done before the child was brought to us.
Yes, CSF might be somebody must have
Yes, ma'am.
done it. Okay.
Yes, yeah.
It's the most important thing in a 3-month-old child, I think, is
Yes.
fontanelle.
The fontanelle. The fontanelle was not, it was not suggestive of a raised ICP.
Yeah, now we can proceed.
Yeah. With this, the MRI was done and the CT scan was done previously, which
Just
was
1 minute,
reported.
Dr. Shankar Gowda. Let's see that Dr. Hingoli team has joined.
Yes, ma'am.
Pallavi ma'am.
Shall I?
I think if I can suggest the screen also, we can see it's not on a slideshow, actually.
Yeah.
Yeah,
I'll put it on slides.
slideshow.
Yeah.
From current slide.
Current
Cut.
slide.
It is slideshow, yeah.
No, it is not yet.
Now
a
it is.
slideshow. Please click the slideshow again.
Double
Yes,
click.
Yes, then wait for a second. See on the left-hand side of your screen, you see from beginning, from current
Okay.
slide.
Second
appearing.
slide.
Yeah.
Yes.
Double
So it's-
click it.
Yes.
Yes.
Double click.
Single click should be enough. Just it is not yet slideshow.
Sir, Team Hingol is in Zoom meeting.
I think we should try to make it slideshow. Then it will be a bit better.
Otherwise, all the screens will be, the slides will be visible.
You can go to toolbar at the lowest part of right side. There
Yes,
also
also-
you will see it.
Team Hingoli, can you hear us?
Wine glass image is there.
Team Hingoli.
Slideshow is appearing on Dr. Shreyans's screen. You can just resume the slideshow.
Yeah.
Yes.
Yeah.
Team Hingoli is joined now.
Is it?
Team Hingoli, can you hear us?
Click on
ma'am.
resume slideshow.
Thank you. Thank you.
Please press resume slideshow because as yet we can see the whole screen. It is not yet slideshow.
I'll try. I'm trying, ma'am. I'm trying.
So what you can do, you can stop sharing this presentation, open
Okay.
in slideshow and then present,
Okay, ma'am.
then share.
Yeah, I'm doing that.
Till then, Team Hingoli can proceed
Yeah.
with their clinical thoughts on this, and they can comment. If they want to ask something, they can ask. Team Hingoli.
Unmute yourself.
Sir, we're not able to join, sir. We joined the meeting on Zoom, sir. So we couldn't get the case properly.
Shall I start? Yeah.
Yeah, Shankar
Can
Gowda,
summarize.
you
Yeah.
can start from the beginning because they are not able to follow that case.
Yeah.
Right from the
Nice.
beginning.
Okay, sir. Yeah. Yeah, is it now slideshow?
Now
Yes.
it is not.
Yes,
Yeah.
yes.
Okay. Team Hingoli, I am starting it for you. Please just
Yes, sir.
interrupt if there is anything you need in between. This was
Yeah,
a
yes.
3-month-old child.
Yeah.
The child was apparently all right a week ago, and the child had episodes of fits since last 1 week and fever. Okay.
You were since 1 week, na sir?
Yeah, 1 week. And this was the child when the child was brought to us.
Yes, sir. Yes, sir.
Yeah, the child was breathing well, as we see. The circulation was well. The eye opening was spontaneous. Tone movement was normal, irritable. The child was not feeding well, and the child had high-grade fever. The sugar done at time 0 was 94 milligrams per deciliter, with sodium of 135, potassium of 2.9, chloride of 102, and pH of 7.593. And CSF was done before the child was brought to us. The CSF, the cells and proteins and sugar, all were normal. And the fontanelle at that moment was not bulging. The urgent treatment was, we loaded the child with sodium valproate with antipyretic, piperacillin tazobactam as an antibiotic, and azithromycin was given. This was the WBC count, 15,200 with normal platelet counts. And the ionic calcium reported was normal of 1.01, and the serum magnesium was 1.42. The reported normal for the lab was 1.5. So we gave a dose of intramuscular magnesium. Anything else you want at this moment?
Is there any drug history, sir? Baby has received any drug before admission?
Before admission, the child had received midazolam, and since the convulsions were persisting, the child was referred to us. And antibiotics were also given. CSF was done, and CSF was normal then. So the child had received an anticonvulsant, midazolam, and had received antibiotics.
From the history, we are suspecting only CNS infection is there. That is
CSF was
CNS
normal. CSF was normal.
Okay. As there is fever, sir, we are suspecting any infection, but the CSF is normal. It can be viral also.
Yes.
Viral incapability, that is causing the disease.
Yes.
What is about antenatal history, sir? Or the marriage is concerned?
Yeah, I'm coming to that, sir. Yeah. And as we were managing the emergencies, we went through the history. This was the 5th child. The parents had lost. There were 2 miscarriages and 2 neonatal deaths. And the neonatal deaths were it was more likely had a similar illness with respiratory episodes where what they had been told. But those were neonatal deaths. They did not know much about the presentation then. Immediately after birth, both the kids had been shifted to the critical care unit, and they lost the kids there. So this was the 5th issue, and no living child was there.
So it can be metabolic disorder also, sir.
Yes, sir.
Yeah. Metabolic disorder.
Yeah.
Symptoms are precipitated by current viral illness, fever.
Yes, sir.
Yes.
Yes. So the pH
What
was
about
7.
the pupils, any changes were there in the pupils?
Pupils were bilaterally reacting, and they were normal.
Equal
Both
in
sides.
size?
Equally reacting.
Equal in size.
Shankar Gowda, can you tell me about the previous neonatal death or previous infant deaths?
Not much was being known by the parents. Both were
At what age they died?
They were neonatal deaths within 2 or 3 days.
3 days, specifically on the 3rd day, 4th day? Or
No, it was around the specifically, I don't remember the thing, but it was 2nd and 3rd day itself. And there were
Yeah.
no signs of perinatal encephalopathy, no evidence of distress or perinatal encephalopathy reported in both the kids.
Yeah, and there was unexpected deaths in a neonate.
Neonates, 2.
And that is 2.
Yeah, and
And
this
there
was
is a
a
co-
second degree consanguinity.
Okay, married to mama directly.
Yeah.
Means.
No, yeah, that was first degree actually. So
No.
it was mama child.
Okay.
This was the second degree consanguinity.
Hingoli, can you elaborate this and come to certain diagnosis or what you are thinking?
And one more, sir, before they go to this, this was the video after almost 24 hours. And there was paucity of movements on the right side. The child had fever there.
Yeah.
This was almost after 24 hours of treatment. The distress had reduced and paucity of movements on the right side was noticed. So with that presentation, we obtained imaging. This was the MRI report. MRI, as we see.
One question before that. What was the development like? Was there any social smile in this baby?
Yes, madam. The child was apparently normal a week ago. The child had developed social smile.
Yes, developed social smile.
Yeah. The child was apparently all right a week ago. The child was around 2.5 to 3 months when this illness started.
At that age, parents may not know also what is normal and what is abnormal in development.
Yeah.
That is the only problem.
And this was the MRI.
Dr. Shankar Goda, do you have 2 devices you are logged in?
I didn't get you.
Have you logged in to 2 devices?
No.
Because there is an echo coming in.
Possible. I'll just check on the mobile. No, madam. No. So this was the MRI. And as we see the left-sided, this was the MRI. Entire left cerebral cortex was swollen. The frontoparietal white matter and internal capsule showed restricted diffusion, also involving the perirolandic cortex. This could be postictal, what was the MRI reader's opinion. And right-sided corticospinal tract showed restricted diffusion. So what we thought was involvement of bilateral white matter could be due to hypoxia is what he suggested. But there were no episodes of hypoxia, significant hypoxia reported within the last week of that child's convulsing episodes. So with the family consanguinity, second degree, there were 2 abortions and 2 neonatal deaths. So as we thought of a febrile infection-related epilepsy syndrome because the CSF was normal, absolutely, with no lymphocytes also. And the sugar and proteins were also normal. And as thought of previously, a metabolic encephalopathy was suspected. It could have been some inborn error of metabolism presenting in that way. So with that presentation, the thought was the child had an unilateral weakness, which was on the right side, and the left brain was swollen. So with that presentation and a consultation with a neurologist,
Dr. Shankar Gowda, please don't disclose the further things.
Okay.
Let the team contribute.
Sure. Okay. So this was what. So my thought process that moment was febrile infection related epilepsy syndrome, some epilepsy, and metabolic encephalopathy.
बघते सर बघते
Hingoli team.
केस प्रेझेंटेशन चालू आहे बघते सर.
Sir,
yeah.
Yes, sir. Going by the history, born out of consanguineous marriage with 4 previous sibling death, and this may be presented in early infantile age group with convulsion precipitated by fevers, and then followed by a stroke. So most likely differential diagnosis will be like suspected metabolic disorder only, and considering the seizures as a presentation, it can be a gray matter disease, as it presented with seizures.
It is a neurometabolic disorder.
Some
also.
neurometabolic disorders.
It can be. Leukodystrophy can be there.
But considering the previous two neonatal death, what you could think?
Sir, there is something like inborn error of metabolism.
Yeah. We know that now that we are dealing with some metabolic disorder, but which metabolic disorder you are thinking? Team Hingoli.
Can you repeat the investigation, sir?
Yes, sir. The ionic calcium was normal. The serum magnesium was borderline less. Sodium potassiums were normal. WBC count of 15,200. And this was the sodium potassium report. And there was no lactic acidosis.
What about ammonia? Ammonia was checked.
And CSF was normal.
The serum ammonia. Ammonia, like lactate you are done.
Yes, ma'am.
Ammonia also.
Ammonia we did not do. It was not available that moment.
And there was no acidosis also.
Acidosis, the pH was 7.5. With
Team
PCO
Hingoli,
of 24.
anything you want to know further or any investigation specific you want to know?
With anion gap of 12. So actually, even before the simultaneously the actic cartridge was also done, which was normal. But the child had metabolic alkalosis. 7.59 was the pH with PST of 24 and bicarbon of 24.
I think there is respiratory part is also there.
Yeah, respiratory part and metabolic also.
So Team Hingoli.
So here we see
okay,
epilepsy, but there was no acidosis.
Urea cycle defect can present without acidosis. No.
And as there was one highlighting thing was that it was unilateral. Even the MRI, if you see, the left brain is highly echogenic, more magnetic than the right side. So the left side is almost white.
But that can be post-ictal also. That's
Yeah,
what they
post-ictal.
can-
It was reported to be post-ictal. But the convulsions predominantly were on the right side.
Right side.
And it used to start with the right side, the upper limb, and then it used to involve the right lower limb too. And occasionally it used to be going on to the left side also.
Yeah, no, Shankar Goda can go ahead.
Yeah. So I think the clinical presentation ends here. So what we thought was, as you said, the metabolic encephalopathy for which a metabolic screen was sent, and even PTH was sent, basically because the ionic calcium was normal, but since the magnesium was borderline, we also sent a PTH. PTH was normal. And we were thinking of a febrile infection related epilepsy syndrome. And the metabolic screen which appeared later on, there was not much, it was not contributory. But the thought was, since I think the next slide is giving the diagnosis, so I'm not sharing that.
What about the team Hingoli? What they think?
Don't share it.
Yes, sir.
Cerebral artery thrombosis, there is, we are suspecting here because of metabolic causes there. Inborn error of metabolism causing a cerebral artery thrombosis. That we are suspecting.
And one differential that is metabolic because so many evidences are there. Circumstantial evidences and family history and all. Any other differential, suppose it turns out to be not metabolic, then what else it can be?
See, I congratulate Team Hingoli saying that basically it is a gray matter disease.
Yes.
It is a familial disease. They have already lost so many children. And the crux of the problem is basically metabolic disease or something which is gray matter degeneration. Somebody said about leukodystrophy, but it is not leukodystrophy. Leukodystrophy doesn't manifest so early. It manifests with spasticity and other things. So your thought process is good. Just go ahead and crack the diagnosis.
I personally think, sir, nothing at this moment clinically would be possible to interpret from whatever information we had. Only way was to proceed was to with investigations in form of genetic and metabolic workup.
No, the blood gas something says something.
Yeah, it was 7.5. Yeah, the pH was 7.5.
Blood gas. What are the bicarbs in blood gas?
It was 24, sir.
Not really bad.
Yeah. And what happened was after the, I forgot to mention, after the magnesium was given, the ABG then was normal.
And blood urea nitrogen is very less in your, that is less than 3.
Yeah.
That may give clue.
What is the role of fever here?
The fever was high grade, and then
Child
within,
was presented with fever. We have to think in that background also.
yeah, it was a high grade fever of 1 or 2.
Yes. So I think what team will think.
Yeah.
Go ahead,
I
Shankar.
thought metabolism
Yeah.
because of history and all, but we have to also keep something else also in mind.
Yeah.
So with the differentiation of febrile infection related epilepsy syndrome and metabolic encephalopathy, we sent gene sequencing, since the child, what the family was more interested was in knowing whether these episodes could happen in the next pregnancy. And we were very skeptical about the prognosis, and the metabolic encephalopathy metabolic screen was sent. There was nothing contributory in the metabolic screen, but the gene reporting, here it was a unilateral weakness with right-sided convulsions and weakness, left bone swollen. A hemiplegic hemiconvulsion syndrome was thought of clinically as a phenotype before we sent the metabolic screen and the genetic workup. So HHE syndrome, as yeah, it is a hemiplegia hemiconvulsion syndrome. It is known to start as a epileptic syndrome. It can start anywhere between in the infancy, and usually the kids, as we see here, they tend to have epileptic seizures which are affecting on the one side of the body, and subsequently they develop hemiplegia, which is of varying density on the same side. And several etiologies have been proposed. They use meningitis or effusions and perinatal or prenatal onset hemispheric small lesions. As in this case, there was no infection, no meningitis or subdural effusion. Of course, protein C deficiency, as one of us have already said, that there could be a thrombus. I think Team Himgoli thought of a vascular insufficiency, and protein S deficiency and lactic hydroxyglutaric aciduria have been proposed as possible mechanisms. But the vascular ischemic lesions, absence of vascular ischemic lesions, basically that rules out a possibility of ischemia. Here we asked for that, and there, of course, vascular ischemia was thought as possibility, but we asked for the MRI, and that they said there was no ischemia. So the pathologic features are including acute edema of the affected side hemisphere, and cerebral hemiatrophy is consistent finding in all patients, but that might present later on. And the standard treatment is carbamazepine. Of course, an EEG was bedside EEG was done, and there were temporal spikes bilaterally, more on the left side, and carbamazepine was started. So within a day, there was a significant response. The convulsions had reduced in frequency. The child's consciousness improved, fever had reduced. So convulsions controlled part 3 days, but restarted again. IVIG were given. The child had apneic episodes and required invasive respiratory support. Yes. So with this,
You ever thought of doing a workup for herpes simplex?
herpes simplex in what form? Immunological workup or PCR?
No, at least EEG.
EEG was done. There were bitemporal spikes, more on the left side.
not about leads, classical features of
Yeah.
HCV. But have you given acyclovir or not in this case?
Acyclovir was not given. We had given azithromycin to start with, and we had given piperacillin and tazobactam. But the absolute, there was unilateral involvement, and that too the whole of the hemisphere. So as such, we had not thought, and the CSF was absolutely normal, madam. And with the family history positive, so significant family history, we had not thought of a single isolated.
We cannot avoid inborn error of
acyclovir.
metabolism. That
Okay.
is there. Not
Okay.
much can be done also for that.
Yeah.
But at least viral illnesses are treatable.
Yeah, but the CSF was absolutely normal, madam.
Maybe because in HCV, what you will find in the CSF?
Okay.
Yeah.
In
any
RBC, as a variable of, as a evidence of cerebritis. So maybe I don't know, Dr. Mahesh, or you can comment on it. Is personally speaking, I would have given acyclovir.
Acyclovir, okay.
Also, as a benefit of
because
doubt.
that is one of the treatable cause of
Treatable
infection.
cause. Yeah.
That's
Empirically, we could have started. Yes.
Yeah.
Yes.
Acute.
And that illness has started with fever.
Yeah. The
That's
illness
one
started
of the
with.
very important thing.
Yeah.
But Shankar Gowda, as your case has significant history, past history, and neonatal death on day 2, 3, or 4, that suggests itself that we are dealing with neurometabolic disorder,
Yes.
and that to intoxication. That's why I specifically asked when the child has died. If child is ill on day 1, the causes are different. And if he becomes ill on day 3 to 5, after consuming some milk, the causes are different.
Yeah.
They can be divided into 5 prototypes. One is intoxication, that is encephalopathy type. Second is seizure predominant. Then we have some different types, because there are some treatable causes like pyridoxine dependent seizures, folinic acid dependent seizures, biotin. So all this can be started, still the report will arrive, because it will take some time.
Sir, there was metabolic alkalosis.
Yeah, and that will suggest that we are not dealing with metabolic acidosis like thing like organic acidemia,
Or even
but
biotin
it is common in urea cycle defect.
Yeah.
Metabolic alkalosis, because your blood urea nitrogen is also less than 3.
Yeah.
That was the clue for me that I'm thinking of urea cycle defect, and urea cycle defect can present in a different way in a different generations, because there was a date on early neonatal death in 2 of the siblings, and they can have later presentation also in urea cycle defect. Okay, and sometimes you have hypoglycemia, then your story is different. If you have liver cell failure, story is different. As madam has said, herpes simplex can present with liver cell failure in a 2nd week in a neonate. 1st week liver cell failure, different causes like mitochondrial hepatopathy, GALD is treatable cause, or HLH is one of the treatable cause of liver cell failure in a neonate. So we should think of all these treatable causes at least when we are dealing with IEM or neurometabolic like things.
Okay.
What happened to the child after that will be very interesting.
Yeah, the child required respiratory support, and after a week, the child succumbed.
Child succumbed?
Yeah.
On which day of life?
That was around after
Which
that,
day
the
of
child was
admission?
almost for 4 to 5 days, the child was on respiratory support, and the child went into deep coma, and the child succumbed.
So it was an intoxication type of invariance of metabolism.
Had you
Sir, the
said in the
metabolic
genetic
screen,
studies,
turned out to be negative.
Metabolic screen is only for 50.
whole exome
50.
sequencing?
Yeah.
The whole
Clinical
exome
exome
sequencing.
or whole exome sequencing will have helped this, and this is
Yeah, whole
definitely
exome
a
sequencing, the report
metabolic
is
disorder,
available.
nothing else.
Yeah, I'm sharing the whole exome sequencing.
See, basically, this is a inherited problem.
Yeah.
Which is presenting with severe neurological infliction and with epilepsy.
Infection may be a precipitating cause.
Infliction. This is not infection, ma'am, because CSF
Infection may be a precipitating cause.
Triggering factor.
This is a epileptic encephalopathy, some kind of channelopathy or that kind of thing.
Yeah. So this was reported, the NGS reported just today. I got the report. It is a track I, one type of exon deficiency, and it is reported as a developmental and epileptic encephalopathy. And the OM-IM phenotype code reported is developmental and epileptic encephalopathy 68, which is supposed to be of uncertain significance, but it is of moderate significance with PM2 and PP3. Is the slide visible?
Yeah.
So with this, I think we have been able to give the family some assurance about possibility of diagnosis in the next kid, or maybe even prenatally.
What you have to do is now with these two mutations, you have to do Sanger sequencing of the parents.
Yeah.
On both mother and father.
Yeah.
And if they are positive for this mutation, then their significance changes from uncertain significance
Uncertain to
the
positive.
Significantly pathogenic significant.
Just today we got the report.
Yeah.
The family has been called for counseling and further investigations.
Hey, Mahesh, as you said, Sanger is necessary in this child.
Sanger?
Sanger is necessary in this child.
Yeah. Sanger with this mutation only.
Yes.
And that cost is not that much. For one mutation, they will take 4,500, I think. So total 9,000 per mother and father. It will cost 18,000 probably. Yeah. But we should do it Sanger sequencing in this child, in this family.
We just got the child's report today. We will be advising that for the parents now.
And good, nice case.
So here, what I feel that this case, what will be the differential diagnosis to start with? Whether what I have got in my mind, whether we are not trying to elucidate the case with the help of next generation sequencing or Sanger sequencing. Is it going to be a shortcut for our examination? Because for as somebody, I might have put my first diagnosis at herpes simplex encephalopathy. Second thing, I would have put this as a MELAS, because it is stroke-like illness and in 3 months old baby. But only thing, looking at the video, this child was very well nourished for any metabolic disorder. The child weight is very nice for 3 months. So I would have put this, must have done 2D echo, whether I am having any thromboembolic phenomena in this child. So, but probably the threshold is going to be lower and lower for doing the next generation sequencing or clinical exome sequencing. And probably as so many investigations have bypassed clinical examination, similarly, this next generation sequencing probably is going to put down the elucidation of differential diagnosis. So wonderful case. So I hand it over back to Kore sir and Lakar ma'am.
This child has so many dates are there. I think it is better to get it done, because lot of if parents also are positive, then no point I think in going for the next child. We can go some other method.
Since we are on HH, this thing herpes simplex, so whatever we are usually sending biofire in CSF, the most 4 important viral infections which are not detected by biofire, and those are dengue, then Japanese encephalitis, and herpes simplex is also one of them. And herpes simplex, many times a single examination will not be helpful. I would have put my weight on giving a cycloid in this child. And repeated examinations, CSF examinations are important for diagnosing of herpes simplex in this child.
I agree with you. I also would have given this cycloid.
Again, that's the beauty of genetics, and now its availability everywhere. Now you can see, though we really think of a genetic disorder, chromosomal issues, or neurometabolic disorders, the third commonest indication for this further genetic workup nowadays is becoming the epileptic syndromes. And I see more number of samples being sent for epileptic syndrome, which have definite inheritance and mutations clearly defined, and more epilepsy syndromes are being defined by the genetic abnormality. So that is definitely an investigation we should keep in mind when we are not getting answers on the routine workup.
Had this been the first episode on the first child, probably we would have gone through the sequence of infections and everything. But since this was almost the 5th child the child family had lost, the focus was more on genetics.
But they can have both. Infection can be a precipitating factor. So we have to manage that.
Okay, ma'am.
That's a great case indeed. Please take over to next one.
Yes.
Thank you, Team
Thank you.
Hingoli. Please, Deepa.
Yes. Thank you, Dr. Shankar Gowda
Thank you,
and
ma'am.
our experts, and of course, Team Hingoli. And yes, this was definitely an interesting case. Now I hand over to Dr. Trupti to start with the next case, please.
Thank you, Dr. Deepa. Now let's watch Team Mumbai accepting the challenge and cracking the next case. For this, I would like to introduce the presenter, Dr. Pawan Devre, who is a pediatric nephrologist, renowned pediatric nephrologist from Nasik in North Maharashtra, working at his kids' kidney clinic in Nasik and also working as an assistant professor in Dr. Vasantrao Pawar Medical College. Team Mumbai members are Dr. Rajesh Kasla, Dr. Ripa Agrawal, and Dr. Sikha Agrawal. So under the guidance of both the experts, let's move on to the next case. Over to you, Dr. Pawan Devre.
Good evening, everyone. Am I audible to everyone?
Yes.
Yes.
And
Yes,
I've
you are.
started the screen sharing, so
Yes.
it's the slide after
Yes.
it's
It's
visible.
visible, sir.
Yeah. So I will. I first of all thank Maharashtra IIP and all of the team for giving this opportunity. And regarding this case, so this was like a case which was managed in a resource limited settings. So not much of investigation was done apart from our routine ones which were available in our setup. So I will right away start with the case. And is the team Mumbai there? Have they joined? So I'll just confirm it.
Yes. Yes, we are.
Yes, sir, they are there.
Yeah.
All three of them are there.
So whenever you want, you just can interrupt me to get more details. But this was a 5-month-old male child, second by birth order, born of third-degree consanguineous marriage, and the first child was is absolutely all right, 2.5-year-old male child, and has no issues. This child was brought with complaints of hoarseness of voice since 2 months, abdominal distension since 1.5 months, and cough since 1 month. The hoarseness of the cry was insidious in onset, and which progressively was worsening, and eventually the cry was barely audible. The abdominal distension was generalized. There was no aggravating or relieving factor, and it was and the cough was very typical. It was associated with intermittent bouts, and those bouts were only after feeding, and it was followed by difficulty in breathing, and this difficulty in breathing used to be transient, so it was more like an aspiration episode which we felt. So with this chief complaint and with HOPI, so what are the possibilities? Yeah. Yes, Rupa.
Can you just remove me from being a co-host, because then I am getting it on my screen that can I admit or like that. So can you just remove me from being a co-host? Ravi madam?
Ripa, you neglect that. Otherwise, there is a chance you may get locked out automatically sometimes. So if you are a co-host, there is less chance that you will be locked out. So you neglect that admit all or not, and focus on the case.
Yep, yes, sir, but it's put that thing is coming on the slide. That's
Just move that drop down window to aside. You can move it.
not possible on my mobile. I'll try. Okay, sir. Yes, Dr. Pawan, please continue.
Yeah, so I'll just show the first slide again. So this was the chief complaint, which was hoarseness of voice since 2 months, abdominal distension since 1.5 months, and cough since 1 month. The hoarseness, a hoarse cry, was insidious in onset, and it progressively worsened, and eventually it was barely audible by the time the child was admitted in the hospital. The abdominal distension was generalized, and there was no specific aggravating or relieving factor, which according to the history, and there was no change seen associated with the feeding and the bowel movement. Cough was used to get exacerbated after the feeding, and it used to be followed by difficulty in breathing. It sounded more like an aspiration episode. So with these chief complaint, the child came to us. So what do you think are the possibilities with just this chief complaint?
Before
Sir, I would rather have the, yeah, please go ahead.
yeah,
You
before
want
going,
further details?
would like to know more about the details. What is the birth weight of the baby? Was his delivery
Yeah, I'm
normal?
coming to that. Yeah, I'm coming to that.
But on these three chief complaints, what are your thoughts? We want to know.
So,
Yeah, what
sir,
we are
I
dealing
feel
with.
so first this child started with hoarseness. So is it so there's some is there some kind of hypotonia also, because something which is first it started like a hoarseness, then there is abdominal distension, but there is no organomegaly which he is telling about. It's generalized distension, and then there is cough. So if I'm not sure, like
No, so I think they haven't proceeded with the examination finding. Organomegaly still may be there.
Yeah.
Abdominal distension,
yeah,
which is more generalized, seems that there is a mass inside, or there is an organ which is enlarging inside, which is pressing the diaphragm, causing cough irritating the diaphragm and causing a cough. So that may be one of the possibilities.
Will you like to put all these three in one of the and what is the then process, pathological process going on, or hoarseness of voice, abdominal distension, and choking episodes during feeding?
depression, we can see that there is some compulsion which
Yeah, this maybe we are looking at a hypotonia-like picture where there is involvement of the abdominal muscles. There is distension, maybe related to the abdominal muscle hypotony, and some or maybe some neuromuscular disorder uh, which is causing weakness of the muscles of respiration, and the child is having cough and hoarseness of voice.
Yeah, good thinking. Yeah.
Yeah. So with the hoarseness of voice, and just with the hoarseness of voice in mind, one thing which we had in mind was whether this was gastroesophageal reflux, whether this was acid reflux, and which was causing some laryngitis, recurrent cough because of that. So, but this GER couldn't explain the abdominal distension. The second thought which we had in mind was hypothyroidism. So whether the hypothyroidism caused the hoarse cry, and whether that abdominal distension was visceroptosis because of the hypothyroidism and hypotonia. So these were the two possibilities which we had in mind. And the further history.
Sir, no,
Yeah.
GER is usually not associated with abdominal distension.
Yeah. So that's what the cough and hoarse cry GER was able to explain, but not the abdominal distension. But then when the further history was getting revealed, so which gave further clues. So this child had failure to thrive. Okay, so this child who is 5 months old, whose birth weight was 2.75, and now he was weighing only 4.8 or 4.9 kgs. I'll come to the anthropometry. He had these episodes of breathing difficulty. Then he also was having difficult to suck, and also later on it progressed and he was having difficulty in swallowing as well. He had swelling over the face and legs, and the major clue which we got in the history was he had regression of gross and fine motor milestones. So the child who could initially was trying to roll over, was trying to reach out for object at the age of 4 months of age, and now in 1 month he was barely able to hold his head and cannot hold on to any object. So further history, I inquired, there was no history of any blood transfusion, no bleeding manifestation. Looking for any congenital infections, the mother didn't had any fever or rash in the 3rd trimester. There was no history of TB contact. The mother also didn't had any tuberculosis during the pregnancy. No history of transfusion and gallstones in the family. No yellowish discoloration. Birth weight was 2.7. So what are your thoughts with this details now on the history?
Yeah, so it is exactly like, so there was neuroregression, and what we are getting is everything is related to the hypotonia and as neuromuscular, and there's white matter, and never, this child never had any convulsions or anything.
No conversion.
No conversions, right? So it's more like a white matter with neuroregression, and it's all neuromuscular, which had started early on. Because if there's difficulty to suck, this hoarseness has come quite late. So this must have come up when immediately after birth only this must have got detected, difficulty in sucking, or this sucking also, progressed later. Was it like the child was breastfeeding well and then later, the suck went off? How was it?
So this child, when he got admitted, that time the child was accepting breastfeed. During the course of the ward, that time we saw that he was not accepting. Whenever the mother was trying to feed this child, that time he used to get this aspiration episodes. And then we discouraged her from giving breastfeeding, and we told her to give Vati spoon feeding. But
so this is
eventually she was.
That means, so this is progressing now.
This was progressing. Yes.
It was now it is now in the progressive. It's not like a static insult. It's a progressive disorder.
It was a progressing disorder.
Sir, was there other milestones? I mean, you mentioned about the regression of motor milestones, but
Yeah.
what about social smile?
So social smile, he was able to give a social smile. Yes.
There was no regression in those milestones. It was
No,
only
eventually, yes, but during when he got admitted, he was giving a social. He was having social smile, and he was most of the time he used to be very irritable. But he had social smile.
Was
So
he able
I
to
think
recognize
our thoughts remain to
contact?
the same process, like we discussed with the symptoms, that there is a, like Dr. Reepa has already mentioned.
Where do you want to put this? Upper motor, gray matter, white matter, neuromuscular junction, muscle disorder, nerve disorder, anterior horn cells?
So I will just tell you. So right now we are at the right track. We have found out the anatomy where this is, and now we just need to find out what could be the wrong with the pathology. So neuroregression is there, and neuromuscular is also right. But then at this age, what could be the pathology which could go wrong with this patient?
At 5 months, no?
Yeah, very young child, 4 months, the neuroregression started, 3 months or 4 months. And so we have neuroregression.
First think about treatable causes. Always.
Mahesh, I really don't think that basically neuroregression at 4 months can be very well assessed by a pediatrician, because you have hardly any milestones which has been developing. So basically, the child definitely is hypotonic. Child definitely has a progression, and more possibilities of a peripheral neural disease rather than or peripheral muscular disease rather than central pathology. Neuroregression, when you start neuroregression, they have only two matters. One is gray matter and second is white matter. When you have neuroregression in gray matter, it is always conversion as a first feature. When you have neuroregression in white matter, you always have a disability, dystonia, and usually present it after 1.5 years or 2 years. Leukodystrophy is always present after 1.5 years, 2 years. So I really feel that basically neither the gray matter, neither the white matter is at fault at this moment.
So that was a very correct comment, because since the social smile was still spared, so this was more of a peripheral muscular problem which was still there. So the thoughts which we had in mind initially, this was like what I went through when I was managing this case. So whether this was inborn error of metabolism, whether this was some mitochondrial disorder I was dealing with, whether this was a storage disorder or infiltrative disorder, or am I dealing with torch group of infection or congenital infection, whether this was some congenital tuberculosis or any torch group of infection. So this is what my thought process were when I was managing this case. So coming to the examination, this child was afebrile. He used to stay irritable, always had this tachycardia because of that irritability probably. He was hemodynamically, he used to be stable, pulses were well felt, always at this baseline tachypnea of around 36 to 40 respiratory rate per minute, regular. Saturation was normal on room air, 98%, 99%, never required any supplemental oxygen. He had facial puffiness, non-pitting pedal edema. His weight and height, length, both were less than the third centile. Head circumference was also less than third centile. He had pallor, some icterus was there. His hairs were sparse, coarse, and brittle hairs. His eyes were normal, and fundus examination was also normal. And facial and periorbital puffiness was there. So this was this child. I will just play this video. So everyone was able to listen to that cry of this child. So
yes, Pawan.
Yeah. So I'll just come to the. So this child, he had this. Despite having this malnutrition, he was having this chubby cheeks and some periorbital puffiness was also there, and he also had this pedal edema, which was non-pitting type. And the peculiar thing which we observed was that he had some nodules which were palpable over this knee joint. He also had this nodules present subcutaneously on this interphalangeal joints. And if you see this interphalangeal joint of this thumb, right thumb, this the joint was very prominent, and he was having this subcutaneous nodule. And similar nodules he was also having in his both the wrist joint and his both the wrist joint, interphalangeal joint, they were swollen. There was movement restriction. The nodules which were present in the subcutaneous part and only in the wrist joint we were able to palpate them, and also in the small joints of both hands and legs. His abdomen was distended. He had hepatosplenomegaly which were firm, non-tender. He had some tachypnea, very fine crepitations were there, some subcostal retractions. His cardiovascular system examination was normal. CNS wise, he used to be irritable, consolable only with the help of the mother, no focal neurological deficit, and yes, he had generalized hypotonia. The deep tendon reflexes were normal, and sorry, they were depressed, and power was normal in all four limbs and also in the central muscles. So any comments from the team or any questions you want to ask, which I forgot to mention here, or if I can add on to the history and examination?
Sir, the nodules that you mentioned were subcutaneous nodules and not a kind of an intra-joint problem, not a joint swelling.
So they were both. There were also subcutaneous nodules, and the nodules were also present at the joint. And
Was
there
it painful nodules?
Sorry?
Any pain was there?
The joints were very painful, means the wrist, he was also only able to do this movement, only this much his wrist used to be able to move. So this dorsiflexion and everything, he was not able to go to the maximum extent. And whenever we used to try doing this wrist movement, he used to cry immensely. So it was painful.
So for this, there are lysosomal storage disorders which can cause a lot of joint swelling, and synovial hypertrophy can happen in lysosomal storage disorders, which can cause organomegaly also, nodules also, and synovial hypertrophy also.
Yeah, so that's very right on target. So to summarize, this child had hoarse voice, distension, neuroregression, failure to thrive. He had swelling over this face, non-pitting edema, hepatosplenomegaly firm, and this nodules which were. So basically, we are dealing with a multi-systemic involvement involving the liver, spleen, joints, muscles, and this was the differential which we had initially in mind. So we were also thinking of infectious causes because we wanted to rule out whatever was treatable. So, and whether we were dealing with any inborn error of metabolism like tyrosinemia or galactosemia or storage disorders, which you rightly mentioned as lysosomal storage disorder. So this was
Fabry's disease is the one which usually causes a lot of synovial hypertrophy.
yeah.
Anyways, please go ahead with the investigation.
So this was the investigation. His hemoglobin was 8.9, WBC was 21,860, and polylympho was normal distribution. Platelets were 11,72,000. His CRP was very high, 114. He didn't had fever during the whole complete hospital stay. He didn't had any documented fever spike. His liver enzymes were deranged. His total bilirubin was 1.1, direct fraction of 0.8. Serum albumin was low, 3.1, and bicarbonate was 20. So these were the preliminary investigation. And anything further you wanted to add investigation wise, which will move you closer to the diagnosis? So I'll just show the slide.
Lipid profile.
Lipid profile. So we did this treatable causes, triple H, torch, and TSH for the horse cry. We did TSH, it was 11.6. So whether this was contributing to that horse cry. So what do you feel? So no. Then his LDH was fine.
TSH is not very elevated for, he was 5 months, right?
5 months, yes. 5 months.
So 11.6 is really
20.
not very elevated for that age group. We would rather like to repeat and see whether this is the, if, as you're asking whether it was
So this
related to that.
ammonia
or
and
not.
lactate we just did, it was acceptable. And for that horse cry, we were just wondering why there was horse cry. So we involved the ENT people and we did a direct laryngoscopy. And they said that there was generalized edema of the vocal cords and the larynx, which they labeled as Reinke's edema. So any comment on this Reinke's edema?
I would like to comment on TSH.
Yes.
I'm audible?
Yes, sir.
Yes. Yeah. As insulin is compared, and insulin levels are always compared with the glucose. Calcium level and PTH level are always compared. Like that, you have to compare TSH with free T4 and total T4, not isolated. Okay. Anything about 10 is significant elevation, treatable, because 6 to 10 is gray area. Less than 6, okay. But you have to compare that with free T4 and total T4. If they are normal and they are all on the higher side, then you can neglect this TSH of 11.6. It can be there in sick child. Okay, or other way around, in a sick child, they are always depressed actually, sometimes. So it has to be compared. What I mean to say that, like insulin levels are compared with glucose levels. Okay, if glucose is low, 20, there has no business to have an insulin level, detectable insulin level. Like that, TSH has to be always compared with free T4 or total T4. Okay, go ahead.
Thank you, sir. So his T3, T4 were normal, and for this TSH, actually we didn't start him on anything, and we further were investigating him, and his hemoglobin had dropped little to 8, and his platelet had become 3,88,000. Liver enzymes were still elevated, and further on checking, his hemoglobin was again still going down 7.7. And eventually when the hemoglobin became 7.1, we were wondering whether this and this during this period, this child had progressively swallowing difficulty got worsened, and we had to put a nasogastric tube for his feeding, and his deranged LFT and his dropping platelet. So this gave us the hint that we wanted to do a bone marrow aspiration with the hepatosplenomegaly and with these reports. So what do you feel, whether marrow was the right choice or a liver biopsy would have given a better answer?
Even if liver biopsy would have been better, LFT is so much deranged to the, I don't know what was the PT-INR here, whether it was normal or not to go
Yeah, it
ahead
was
with
normal. It was normal. The INR was normal.
See, prior to see that basically the hemoglobin is dropping and the platelets are dropping, let Mahesh say why the CRP is in 3 digits, why the counts were so high, why there was a thrombocytosis in a case of storage disorder, and are we expecting something which has gone wrong and which can be diagnosed by bone marrow? Mahesh, please.
Yeah, I'm also worried actually of that high CRP, because there is no fever and there is inflammation. As this inflammation can be because of endotoxins, I don't know, because there is a storage disorder and which is increasing. That's why bone marrow infiltration already occupying the space. That's why platelets are coming down, HB is coming down. Now there are two things: whether the child is going for HLH, where the child is become very sick, or it is just because of the storage, whatever. And which are the storage disorder we are thinking within this first 6 months, because hurler will come by after 6 months to 2 years. Hunter will come 2 to 4 years. Third, Sanfilippo will have only mild ADHD-like feeling, and Morrico will come after that. Okay, so not MPS-like, but other. Sika has said that she is thinking of Fabry disease. Absolutely, because subcutaneous nodules, tight or painful joints, hepatosplenomegaly, all this fit into that. I am going with that storage disorder. And basically, if you pick that storage disorder and it is very painful, that's why the child is irritable. And bone marrow may or may not give you a diagnosis sometimes. Then you have to go with again genetics. Okay, but as you may have that diagnosis, that's why you have put that case. Maybe bone marrow will give us, because that is easy to do.
Actually,
and,
I just wanted to ask about here serum ferritin and LDH level were done or triglyceride level were done.
So we didn't do the triglyceride. Initially, we were thinking of just the storage disorder.
Yeah. Only one disorder, and right from the beginning, we are thinking of storage. You go ahead with storage, right? Yes. No problem.
But very true that we
so
were
intense in the biopsy, we can get the steatosis and the vacuoles that are found.
Yes.
That can be identified before the genetics, if we are thinking like we should not directly go to genetics.
In this investigation, even we were not able to find out why this CRP was so high, and with this ferritin, and that's why we thought we should do the bone marrow, whether it was just the HLH which was just coming up, so we can get the diagnosis through the bone marrow, or we can also find out any infiltrative or storage disorder. And yes, we were thinking of lysosomal storage disorder. This was the differential we had in mind, Gaucher's or Niemann-Pick disease, which we were thinking. And
jaundice was unconjugated or conjugated?
It was conjugated. It was very mild. It was just 0.8. Yeah. This was the
if with that synovial hypertrophy and all these organomegaly, my pointers would be rather Farber's and Fabry's.
Yeah.
Or there is another entity called hyaline fibromatosis.
So
infantile hyaline fibromatosis.
Yes, infantile hyaline fibromatosis.
Yeah.
So I'll come to the biopsy. This was the bone marrow aspiration report, and it was showing this foamy lipid-laden macrophages, which were scattered throughout the bone marrow slide. And this was reported as lipid-laden macrophages and was suggestive of some lipid storage disorder. and the pathologist were gave the diagnosis of Niemann-Pick disease or anything. So with this picture, so I think Shikha has already given us the right pinpoint diagnosis. This is Farber's disease. This, like I told you, this was managed in a totally resource limited setting. So we didn't do any MRI, we didn't do any whole exome sequencing. Barely all the investigations were managed within the cost frame of like 5,000 rupees. And when the biopsy report came, we were thinking of Niemann-Pick disease, but the Niemann-Pick disease was not able to explain that subcutaneous nodules and the painful joint. And Farber and other thing which was going against Niemann-Pick disease, that the symptom starts appearing at the end of the first year, and then the child succumbs to the illness in the 3rd or 4th year of life. This child manifested at 3rd month of life, and he was progressing very rapidly. So Farber disease was explaining this. And when we reviewed the literature, it has a very classical clinical triad of painful joint deformity, subcutaneous nodule, and hoarse cry. And yes, they also mentioned that there is a edema, chronic edema of the vocal cords and also of the larynx. And that's why the ENT people, they labeled it as Reinke's edema, which is also another term for any chronic edema of the vocal cords. So it is a progressive granulomatous inflammation, and probably this inflammation caused the high CRP, which I was able to postulate.
Sir, if I can add, like you very wonderfully managed and investigated the case, but MRI, even in a full resource setting, is not required in this case. A simple sonography can also tell the synovial hypertrophy that the child has, and you did perfectly the biopsy, which was done to show the formulated replicated macrophages.
What about
So
fine
I think
little
this is
accumulation
one.
of nodules?
Sorry, madam.
So there is, these are nodules which have deposits. They have a lot of gum hypertrophy also, if I'm not wrong. I'm not sure whether this child had those gum hypertrophy or not. But this typical picture, doctor, if you see, if any resident is here, this joint is typical of a synovial hypertrophy. This look of the joint, where you feel that the wrist is doubled up almost.
Yeah, exactly.
So this is one thing which is very typical of having a
This image
Farber's
was taken
disease.
from the net, but this exactly how the rest of this child looked, and it was looking like it was studded with some nodules and also this interpharyngeal joint.
So
And
if you would have shown this picture first, I think we all three would have given you the diagnosis.
this
in
was
first
the
slide.
image taken from the internet, and the images which I showed was of the actual patient, and he didn't had this significant synovial hypertrophy. So maybe
Any gum hypertrophy
Any
that the child had?
swellings,
Gum
which were not
hypertrophy?
on the joints. Sorry.
Sorry, madam.
Any swellings which were not on the joints.
There was some subcutaneous nodules which were there, and one more thing in this Farber's disease is that they also have this shiny skin, and they also have this non-pitting type of edema.
Yeah. You have a differential diagnosis based on the age of presentation.
Yes.
Within this first 6 months, ICL disease, sialidosis, that lipid, and this Fabry's will come. After 6 months to 2 years, Hurler will come. Hunter will come after that. Like that, you have to go. And it is a multi-system disorder where liver is involved, spleen is involved, larynx is involved, and joints are also involved, and lungs is also involved, I think, because he has tachypnea, no?
Yeah, he had tachypnea, very fine RALs were there. And
RALs, scrapes, okay.
So they also have this deposition in the interstitium, which classically will give rise to that baseline tachypnea. So after the biopsy and after, means like Shikha must have already seen, or I actually didn't knew this diagnosis, or I was not thinking about Farber's. I was thinking of Niemann-Pick. Everyone here in our unit was thinking of Niemann-Pick disease. But then the review
Niemann-Pick type C, you want to say?
Yeah. But then the Niemann-Pick
doesn't have nodules.
It doesn't have nodules. And it does not cause the hoarseness of voice.
Mainly it is the jaundice and hepatitis B.
Yes. And again, the median survival of this Farber disease is 6 to 9 months. Unfortunately, the child followed the same track and he expired at the age of 6 months while he was in the ward. And because his lungs were worsening, his illness was worsening.
Similar presentation can be there with infantile systemic helinosis, but
Yes,
the
very
there will
similar.
be a mild thickening will be more than the nodules. It is a callosities which helps the differential between the fibers and the infantile systemic helinosis. There will be
And sir,
callosities will be more
organomegaly is very less in
less, yeah,
less in organomegaly is
and
very
more
less.
of a skin and joint manifestation than that of the
And lot of gum
gum
hypertrophy also they
hypertrophy.
have.
Yeah, that is the closest differential I can think.
Closest differential. Yes.
Yeah, I was impressed with the presentation and as well as the people who cracked that very easily.
Yeah.
The presentation was really good.
What I find, the initially, as Dr. Kore has said, where is the anatomy? And as the traditional teaching goes, in this case, anatomy was very difficult to put it. So it was everywhere. So since it is a hoarseness of voice, which storage disorder starts with hoarseness of voice, unless until there is, because first diagnosis for me would have been the laryngeal nodule, vocal cord nodule is there or not. So it is started with hoarseness. No, hypotonia will start with hoarseness. And also had neuromuscular junction, hypotonia, opisthotonus, edema, pallor. So it goes a multi-system. So it was initially storage disorder. But he said that there is no cherry red spots. So since cherry red spots were not there, again Niemann-Pick was ruled out. So to start with, and we were just pondering whether liver biopsy is to be done. But for all storage disorder, if we are not going to do enzyme studies and other things, so bone marrow should come first. And bone marrow will give us a diagnosis, at least short list, and genetic studies will tell us. So bone marrow will always prevail than liver biopsy in any case suspected of storage disorder. So it was a wonderful presentation of storage. Epidemiologically, Niemann-Pick would have been, as generalist, I would have put the diagnosis of Niemann-Pick as epidemiologically. But once these nodules and painful joint and everything come together and absence of cherry red spots, otherwise bone marrow would have said me to suggest that this diagnosis is Niemann-Pick. But why there is no cherry red spot? Why there is so nodules, painful nodules and joint and extra-articular, intra-articular, and probably these same nodules in the vocal cord was also causing the hoarseness of voice. So it was everywhere, CNS, neuromuscular, organomegaly. So most likely it was a storage disorder, Niemann-Pick. But since it was not fitting into Niemann-Pick, as Shika has said that it was a perfect clinical diagnosis made on these findings that it is most likely to be a Farber disease. I congratulate all the team particularly and presenters also. And very nice insights from Dr. Kore and Lakkar madam. Wonderful. So I think first session was very nice and everybody is enlightened.
Thank you, sir. And
thank you, sir.
Anybody wants to add something into this?
Yeah, so I would just say it is an autosomal recessive disorder. So parents, if they are planning another pregnancy, they should definitely be counseled.
so this was very unfortunate. There was an unfortunate story that after this child was born, the mother underwent tubal ligation immediately after the delivery, after the section. So the father was so heartbroken that he wanted a cure for this child because the tubal ligation has already happened and they cannot plan a second child, third child after this. So, and also they didn't have the resources to send the whole exome sequencing or also the enzyme studies. So again, we cannot make a pinpoint, we were not able to make a pinpoint diagnosis for this child.
Okay, sir.
Rather than enzyme diagnosis here, it will be the again full exome sequencing, which will pinpoint, because again lysosomal storage disorder and enzyme studies will tell us what is this, but antenatal diagnosis again the genetic study will be more important and it may pinpoint to that particular gene which is called as ASH1 gene or like that.
Excellent cases indeed, very well presented, and congratulations both the teams for giving their best. Mumbai cracking it and Hingoli very near to it. That was really fantastic session and intellectual as well as clinical enrichment for everybody of us. Thank you so much. And let us hope for the best, better, best next session like this one. And thank you, the audience, as well as the experts and all the seniors contributing to this session. Thank you so much.
Thank you.
Pawan, stop sharing the screen.
Yes.
Thank you. Thank you so much, everyone. So it was wonderful case discussion and very wonderfully and skillfully cracked by Dr. Sikha. So congratulations to everyone. Now, yeah. Yes, anyone would like to talk? Okay, so with this, I would like to call upon Dr. Neha Singh to give vote of thanks. Dr. Neha.
Thank you, Trupti. On behalf of MAHAIP, I, Dr. Neha Singh, first of all, would like to thank respected Dr. Upendra Kinjewalekar sir for accepting our invitation, for being our guest of honor and giving his blessings today. Also thank our experts for today's case challenge, Dr. Bhavna Lakhan ma'am and Dr. Mahesh Kore sir, for giving their expert comments, which were very inspiring and helpful. Also would like to thank both our case presenters, Dr. Pawan Devde sir and Dr. Shankar Gora sir, for presenting us such interesting cases today. Would like to thank and congratulate both the teams of today. They were equally wonderful. Dr. Nitesh, Dr. Swapnil, Dr. Amol from Team Hingoli, as well as Dr. Rajesh, Ripa ma'am and Dr. Shikha ma'am from Team Mumbai for actively participation, all the brain hunting and trying to crack their cases. Would like to thank Dr. Pramod Kulkarni sir, even being so busy, sir gave his support and time, went through both the cases and guiding our presenters. Thank you so much, sir. I would like to thank our MAHAIP President, Dr. Ramakant Patil sir, and Secretary General, Dr. Amol Pawar sir, for starting again the very favorite of all, MAHAIP Case Challenge, and giving us the opportunity. Also thank our 5 zonal coordinators, Dr. Rajendra Khadke sir, Dr. Anjali Gokarn ma'am, Dr. Deepa Khadke ma'am, Dr. Ravindra Sunamle, and Dr. Naresh Tyade sir, for giving their full support to us. Thank you, Dr. Deepa ma'am and Dr. Tripti, for moderating today's case challenge. Also, thank you, Pallavi ma'am, for all the technical support given by her. Last but not the least, I would like to thank all the attendees on Zoom as well as YouTube Live for joining us today. Thank you all and good night.
Thank you, Dr. Vaibhav Pustake, for being there as our colleague and an MMC observer also.
Yes, sir.
First observer who was still last.
Yeah, because he's pediatrician and academician. So he's more interested in learning and enriching and contributing rather than being just observing.
Thank you, Kore sir. Thank you.
Thank you. Thank you.
Thank you, Alok Gupta sir, for being there continuously throughout the session.
Thank you. Thank you. Wonderful learning sessions. And it was a great learning session. And congratulations to MAHAIP and the teams and to the organization. Wonderful.
Trupti, Neha, Anjali ma'am, Deepa, Khadke sir, please make it, the cases should be ready in next 2-3 days for the next session. And from next session onwards, we'll be announcing in that session only. There will be 2 cases from one team, which teams we are going to be participating in that particular session. If we are already cases in hand and teams who are going to participate are also willingness is there in our hand. So we'll be declaring in the session about the next session.
Last time सारखंच करू कारण ते थोडं इंटरेस्टिंग राहतं.
11th hour ला ठेवायचं. Okay.
नाही केसेस आमच्याकडे आहे, पाठवतो.
Yeah. So appeal to everybody to, and yes, the person who is sending the case will get the opportunity to present it.
महेशकडे खूप केसेस आहे. महेशने त्याच्या ज्युनियरला सांगायचं.
भरपूर